Good afternoon. At the outset, I thank the organizer for giving me the opportunity. I'll discuss my experiences with the management of Fernbody airway, which are presenting as a dire emergency. As such, the management of Fernbody airway is a challenging job. Now, overall, the sudden onset of respiratory distress due to Fernbody aspiration is one of the leading cause of accidental death in the age group of 1 to 3 years. It is more common in male, and 70% cases of choking death is caused by organic foreign particles. The infants and children, they decompensate more quickly in comparison to adults because they have a narrow airway. The unaided child with a fully obstructed airway will die within 4 to 6 minutes if no help is given. And that is the reason failure to manage airway is the leading cause of death. So prompt diagnosis and early focused intervention is crucial for better outcome. Why children are more prone to Fernbody inhalation? There are so many reasons. First is the natural urge to explore the world by putting the objects into the mouth. They do not have the molar teeth, so that they cannot crush nuts. Crying and playing while eating, the lack of parental supervision, they have immature glottic reflex, incomplete coordination of mouth and tongue. Now what happens if there is an acute choking episode? Either the Fernbody is expected out or swallowed, or if there is a complete obstruction of the laryngoscope, the child will die, or there may be a symptom-free period, which is a deceptive period. For some time, patient will be asymptomatic, or there will be persisting symptom, and later on the child presents with complications like pneumonia, lung abscess, or bronchiectasis. Now, these are the common signs of choking attack. Patient is unable to talk, breathe, or cough. There is a loss of consciousness, and the child becomes blue due to cyanosis. Now, usually in these patients, we advise X-rays. The most common X-ray is X-ray soft tissue neck lateral way. It's very useful X-ray. If there is a marked dilatation of larynx in the lateral view, that is a very important sign of Fernbody in the airway. Second is X-ray chest, plain X-ray. This may show 4 types of pattern. First is the X-ray chest will be normal. If there is no obstruction into the airway or obstruction is near normal, this is deceiving. Second is a check wall type of obstruction, which is the most common type, and patient usually X-ray usually show the unilateral obstructive emphysema. This is almost diagnostic of Fernbody in the airway. Fourth is a ball wall or a stop wall type of obstruction. It does not permit the entry of air into the bronchus, and patient will develop collapse and consolidation of the lung. Now, CT chest and virtual bronchoscopy, it's a very useful investigation. The main advantage is the very high sensitivity in the diagnosis. It exactly determines the size, and shape of the Fernbody. And another advantage is the bronchoscopy can be avoided in case of a negative virtual bronchoscopy. The main disadvantage is it is a costly investigation and it's not everywhere available. Now, management algorithm. If a patient has aspirated Fernbody leading to airway obstruction with stridor, we should go quickly for the history, physical examination to assess the severity of problem. And if it is very severe, we have to urgently establish the airway either by bronchoscopy, tracheostomy, or pupillotomy. Or if it is a gradual onset and mild symptom, we should always go for virtual bronchoscopy followed by bronchoscopy. Now, this is the Heimlich maneuver which has been described in literature as a first aid help, but it can prove dangerous. It can convert partial obstruction into the complete obstruction. Now, rule of thumb when to perform bronchoscopy. If any of these things are positive, if a history is positive, physical examination is positive, or X-ray chest or lateral view is positive, we should go for bronchoscopy. Now, anesthesia. We usually go for relaxant anesthesia. It is much better than spontaneous or inhalation anesthesia, because the main advantage of relaxant anesthesia, it prevents the dislodgement of Fernbody at the level of glottis while doing bronchoscopy. It gives better exposure of glottis, and relaxant also gives pre-bronchoscopy better oxygenation. Now, usually we perform all bronchoscopy with ventilating rigid bronchoscopy. It is the gold standard for the management of Fernbody airway. which is having prismatic light deflector. We should have all size of forceps available, scope side depending on the age of the patient, and surgeon himself should check all the instrument. There is a very famous saying by the father of bronchoscopy, Jackson: 2 minutes of advanced preparation will save 2 hours of struggle. Now, technique of removal is standard. We visualize the larynx, vocal cords with the help of anesthetic Macintosh laryngoscope. Removal involves 3 stages. First is the inspection of foreign body to study the forceps space. Second is extraction of foreign body, and we always go for check bronchoscopy after removal of foreign body. Many times there may be remnant of foreign body or secretions are there. The removal is en bloc. That means the foreign body, forceps and bronchoscope should be removed as a single unit to prevent the dislodgement of foreign body. We should always establish the patency of other bronchus before we attempt extraction, and if foreign body is small, it can be removed through the lumen of bronchoscope. Now, what precaution we should take at the level of glottis? So, this is the most common site where the foreign body may get dislodged, and it is also known as zone of death. So, we should lift the proximal tip of the bronchoscope upward so that the forceps foreign body at its tip passes to the posterior part of the glottis, which is more wider and spacious, and it will prevent the dislodgement of the foreign body. Now, foreign body of subglottis and glottis, they are the most dangerous of all airway foreign body, and because they are life-threatening. This is the narrowest part of the child larynx, though they account for only 4% cases of foreign body airway, usually present with acute emergency, which requires immediate attention and management. Diagnosis is often difficult because it may be confused with the other causes of upper airway obstruction. Role of tracheostomy: in most of the cases, we are able to avoid tracheostomy. Now, a few examples. First is a foreign body glottis, a peanut pericarp. A 1-year male child presented in the odd early morning hours with aphonia and severe respiratory distress. The oxygenation was just 80%. There was a severe intercostal indrawing and respiratory stridor. Air entry was reduced on both sides. XHS was normal. Urgent bronchoscopy was done, and foreign body peanut pericarp was removed. Post-operatively, patient had a laryngeal edema, and it was managed by medical tracheostomy, that is the high dose of steroids. Another case, the foreign body THORN seed is an uncommon foreign body, also the Gokhru seed. In a 6-year male child with a stridor and aphonia, there was a definite history of foreign body aspiration, poor oxygenation, intercostal indrawing, X-ray soft tissue neck showing the typical shadow of foreign body in the subglottis. It was removed by bronchoscopy, and this is the photograph of foreign body. The foreign body metallic scrap. It was just a very small child, just 6-month female, presented with severe respiratory distress, reduced air entry bilaterally. The father was Blake Smith, and urgent excess of soft tissue neck, and the virtual bronchoscopy showed the radio-opaque shadow at the level of glottis, and bronchoscopy was done, and the metallic scrape pieces were removed. Then the retrospective history revealed that the elder brother had inserted the foreign body into the mouth of the younger sister. The foreign body fishbone in the glottis, we can see in X-ray and virtual bronchoscopy the shadow of foreign body. The patient presented 3-year male with there was a definite history of foreign body, respiratory distress and change in voice. Virtual bronchoscopy revealed the shadow of foreign body, and this is the foreign body removed. Now, another interesting case, the 4-month male presented with severe respiratory stridor. There was no history of foreign body aspiration, but the X-ray revealed a shadow of foreign body in the trachea. And this was the nose ring, which was removed by bronchoscopy. The retrospective history revealed that the nose ring of mother was missing, and the child was in habit of pulling the mother's nose ring frequently. The transglottic foreign body BETEL nut. It was a 4-year male presented with severe respiratory distress and aphonia after a fall. Child was referred to us as a case of head injury. There was no definite history of foreign body, but the father was in habit of chewing BETEL nut, and child inhaled that foreign body and fell unconscious. The virtual bronchoscopy was done that revealed a transglottic big foreign body, and it was a BETEL nut removed by bronchoscopy. Now, transglottic, another foreign body, the rusted nail. The same symptoms are there, and the X-ray showing typical radio-opaque shadow of nail, and this was the foreign body removed by direct laryngoscopy. The foreign body is subglottis. plastic whistle. The child was very small, just 2 months male, and he had a sudden onset of respiratory distress and stridor. X-ray showed some shadow of foreign body in the subglottis and glottis region, and this was the plastic whistle which was removed by bronchoscopy. Retrospective history revealed that the elder brother had put the whistle, so we had to educate the elder sibling not to offer unnecessary thing to the smaller sibling. The custard apple seed in a 5-year male presented with severe respiratory distress and stridor. This foreign body is challenging because foreign body is very smooth and slippery in nature, and this is seen more commonly around the Diwali season. The X-ray soft tissue neck showing marked dilatation of the larynx, which is a very important radiological sign of foreign body. The post-operative subglottic edema. The many patients with the foreign body in the subglottis or glottis, they develop severe distress after removal of foreign body. This can be very well managed by medical tracheostomy. We follow this regime. We give dexamethasone 1 milligram per kg every 15 minutes for the first hour. Then every half an hourly for 2 hours, and then 1 milligram every 4 hourly for 24 hours. And in most of the cases, with the help of medical tracheostomy, we can avoid tracheostomy. Now, tamarind seed. It is the most challenging and one of the most dangerous foreign body in the airway. This patient presented to us with cough and breathlessness for 15 days. The virtual bronchoscopy showing a large swollen foreign body in the right main bronchus with pneumonitis. And because it was a long standing, it got swollen and it cannot be removed through the glottis. So we performed first elective tracheostomy. Otherwise, what happens, we try to remove the foreign body, it gets impacted at the level of glottis. And if something is not done immediately, the patient will die immediately. So it is always better to perform the elective tracheostomy. So tracheostomy, usually we should always keep ready, the tracheostomy tray ready whenever we perform bronchoscopy. And that may be a life-saving procedure, but most of the time we can avoid it. Now, this is a foreign body Gokhru seed, again a THORN seed in a 6-month female, having progressive increased stridor, cough, respiratory distress. There was no definite history of foreign body, but X-ray was showing marked obstructive emphysema on the left side, mediastinal push on the other side, and there was severe obstructive emphysema on the left side, and it was removed by bronchoscopy. Usually, the THORN seed gets impacted in the oral cavity or the glottis, but somebody tried to push the foreign body. That was the reason it went into the left main bronchus. It was a female child. Now, bilateral foreign body. Usually, bilateral foreign bodies are uncommon. Mostly, we see unilateral foreign body. This child presented with severe respiratory distress. There was no history of foreign body aspiration, and there was sudden drop in oxygen saturation to 40%. So, immediately intubation was done. Patient was put on ventilator, and after that, the virtual bronchoscopy was done. You can see the endotracheal tube in situ, and that revealed there was a foreign body in both the bronchus, and it was removed by bronchoscopy. There was a gram seed in both the bronchus. So as such, the bilateral foreign body in the bronchus are uncommon. Another patient, bilateral foreign body, it was an adult patient, was having cough and cold for 2 months. There was no history of foreign body aspiration. The chest colleague did a flexible bronchoscopy. He could see something blackish in both the bronchus. But while doing the procedure, patient went into respiratory arrest. He was intubated immediately and revived. And the virtual bronchoscopy was done, showing the foreign body in both bronchus. And each were the pieces of the bead bolus, which were removed by the rigid bronchoscopy. We should always remember, whenever there is a foreign body in the airway, the rigid bronchoscopy is the gold standard for foreign body removal. Now, moving foreign body can change its position. Now, it was an 8 months female having symptoms like cough and cold. The virtual bronchoscopy revealed foreign body in the right main bronchus. And while shifting the patient to operation theatre, the foreign body got dislodged from the right main bronchus to subglottic, precipitating the acute respiratory distress. So, urgent bronchoscopy was done, and a big berry seed was removed from the bronchus. We should always shift the patient in the operation theatre when the team is ready for performing bronchoscopy. Otherwise, in the operation theatre, child usually cries, and that may lead to the moving foreign body. Another example of moving foreign body, 6-year male having severe respiratory distress, He was put on the ventilator, he was revived and then discharged. 1 month back, again patient developed progressive cough and cold. X-ray chest was normal, virtual bronchoscopy was done, and that revealed a foreign body in the right main bronchus. Before bronchoscopy, again foreign body got dislodged to the subglottis and caused acute respiratory distress, and by performing the bronchoscopy, the BETEL nut sheet was removed. So virtual bronchoscopy plays a very important role when the symptoms are long-standing. Aspiration of esophageal foreign body. This child had a foreign body in the esophagus, presented with absolute dysphagia, but he vomited. He had a vomiting, and after vomiting, he inhaled the foreign body. And we can see the X-ray. Barium swallow is normal, but there is an obstructive emphysema on the other side. The virtual bronchoscopy is showing a very large foreign body, right from right main bronchus, carina to the trachea, and it was removed by bronchoscopy. It was a large berry seed. Complication of foreign body BETEL nut. He was a 4-year male child, was having symptoms like cough and breathlessness for 2 months. X-ray chest was normal. There was sudden deterioration in the condition of the child with respiratory distress and cyanosis. And urgent tracheostomy was done to relieve the respiratory distress, and it was followed by bronchoscopy. And there was a large BETEL nut seed in the region of subglottis. This is a child where tracheostomy was performed, and this is the foreign body. We should remember always the BETEL nut in the bronchus can dislodge any time with the bout of cough and gets impacted at subglottis due to irregular shape and creates acute emergency. So whenever BETEL nut foreign body is there, we should remove it as soon as possible. Now, foreign body presenting with pneumomediastinum and the surgical emphysema all over the body. The patient was a 3-year male having respiratory distress and subcutaneous emphysema all over the body. The virtual bronchoscopy revealed there was a pneumomediastinum plus surgical emphysema and a foreign body in the right bronchus. It was removed by bronchoscopy. The reason for pneumomediastinum and surgical emphysema is the rupture of alveoli due to the excessive cough. So this is an unusual presentation of foreign body in the airway with surgical emphysema. Again, the patient with foreign body Tamarind seed, most dangerous foreign body with respiratory arrest. The child was a 3-year male, acute respiratory distress followed by arrest. He was intubated and revived, and later he was extubated. And the virtual bronchoscopy revealed a big foreign body in the right main bronchus. Urgent bronchoscopy was planned, but on the table, while due to excessive crying, caused foreign body to dislodge into subglottis, causing cyanosis. So there was no time to give anesthesia to the patient, so we passed the bronchoscope without anesthesia, and foreign body was pushed back into the right main bronchus and then removed gradually. Foreign body Corn seed causing, this is the pre-op X-ray showing complete collapse and consolidation on one side. This is a post-op X-ray. The virtual bronchoscopy showing total whiteout on the left side, and this is a foreign body Corn seed which was removed. Whenever there is a complete unilateral collapse of the lung, it is a dire emergency because there is one lung is already collapsed, there is a spillage of secretion into the other lung which can lead to the more emergency. Now foreign body, the ball pen tip. This is usually seen in more grown-up school-going children. This is the X-ray chest showing complete collapse on the left side. Virtual bronchoscopy showing whiteout on the left side. This is a post-op X-ray, and this is a ball pen tip which was removed by bronchoscopy. Now, it's not easy to remove the ball pen tip from the bronchus. It frequently gets dislodged at the level of glottis. In the very first case, we made more than 15 to 20 attempts to remove the foreign body. It could not be removed. It used to get dislodged at the level of glottis. So we performed tracheostomy, and it was removed through the tracheostoma. Then we studied the why it getting dislodged at the level of glottis by using a dummy foreign body. In all subsequent cases, we used a special technique to remove the ballpoint tip. The foreign body should come in alignment with the lumen of the bronchoscope. If you hold the forceps of the foreign body opposite the beak of the bronchoscope, then this will come into the alignment. But if it is on the same side of the beak, it will be away from the lumen of the bronchoscope and it will get dislodged. But if it is in the line of the lumen of the bronchoscope, in a single attempt, it can be removed and tracheostomy can be avoided. The foreign body plastic bead It's a very large, very slippery foreign body. In the first bronchoscopy, it could not be removed by rigid bronchoscopy. So we made many attempts. Next, this is the foreign body X-ray. The next day we planned bronchotomy by the pediatric colleague. But before doing a bronchotomy, we again attempted endoscopy, and just gentle maneuver, we could remove the foreign body. So hence the bronchotomy was avoided. Bronchotomy is an alternative for all cases where foreign body is very large. Cannot be removed through the bronchoscope or glottis, then we have to open the bronchus by bronchotomy. So take home message, the diagnosis of foreign body airway depends on the high degree of suspicion in a child with respiratory distress. Virtual bronchoscopy is a very useful investigation. It should be available in the hospital premises so that we can make an immediate diagnosis of exact size, shape and location of foreign body, and urgent bronchoscopy can be done. In cases of acute airway obstruction due to foreign body, cyanosis, bronchoscopy can be passed without anesthesia to save the child. The patient should be kept in ICU with mother to avoid crying, which can lead to dislodgement of foreign body and can create an acute emergency. Till all preparation for procedure are done, all measures to secure airway must be ready during bronchoscopy. The team management is important. Everyone in the team should know their job. We should always educate grandparents, parents and elder siblings not to offer unnecessary thing to the smaller child. Thanks.